Hey, good evening, everyone. Welcome to our second seminar. Tonight we'll have Dr. Reese and Suzanne, and the topic will be about lab results and imaging studies. We hope that you enjoy our second seminar, and we're very happy that a lot of you have participated tonight. Dr. Reese, you can
Yes,
start.
yes. Thanks, Lydia, and thanks to those of you in the audience. We were delighted that many of you came for the first session and asked questions and actually submitted some very insightful questions that we seek to try to answer as we can, because as we evolve this series, we really want it to be a dialogue, a good interchange where we can provide you information that's useful as you deal with myeloma. A brief review of the goals of this series, which haven't changed, is to give both the scientific but also a patient-oriented perspective of myeloma, how it behaves, what's its biology, and to build on a background that we can take this series into a bit more complicated set of presentations to talk about the newer treatments, how they work, and particularly what about their availability in Canada. And this will be very relevant for the new immunotherapies because they work quite differently from our what we call conventional drugs. And again, we want to provide a platform where our participants can ask questions and get useful answers. Next slide, please. I'm going to start by just reviewing a couple of issues. And we did show this slide last time that talks about some of the main challenges our myeloma patients face. In particular, low blood counts, particularly anemia, and Suzanne's going to address this further in a minute. And the other biggie for our patients is lytic bone damage. It looks like holes in the bones, as you can see in those x-rays. It's really thin areas, but that is a hallmark of myeloma. Decreased kidney function, and of course, the risk of infection from the disease and its treatment. Now, as we go through looking at interpreting the tests we use to assess these challenges, we're going to mainly talk about the tests. We won't have time in this session to talk about what we do with abnormal values. That will come in a future session. Next slide, please. I'm going to turn it over to Nurse Rowland now. I tend to be the more scientific person, and Suzanne brings me back to reality. What if I'm sitting in the chair listening to having a diagnosis and what is going to happen and these millions of tests I'm going to have? What do we do with that information? So take it away, Suzanne.
Thanks, Dr. Reese. I'm certainly having myeloma certainly isn't funny by any means, but sometimes bringing a little bit of levity to a situation can help in clearing things up. Slide, please. So I'm obviously not an artist. I'll explain what this is. And the reason I have a clown on the previous slide was when I started in my role at Princess Margaret, and there were many questions about, why do I have to have so much blood work drawn, and lots of questions about how can you tell if this is happening, etc. So I one day I took someone's blood results that I had printed out, and I just turned it over. And again, not an artist, but I drew what I ended up calling my clown hand. And I explained to the patient and their loved ones that every time that I saw them in my clinic, and these were patients that were receiving treatment, sometimes IV treatment, or they were coming in for transfusion support or hydration support. I always organized to have blood work drawn. So I would explain to them that the first thing we always made sure that we had was an up-to-date CBC or a complete blood count. And I'll speak more to that in a minute. The other thing, the next thing was their bones. Was there any indication that the patient had any new or worsening bony involvement? And through the two things that we would look for, sort of to guide us towards how the bones were doing, was did the patient have an elevated calcium? So if a patient has an elevated calcium, it could be that the lytic lesion, alytic lesion, or multiple lytic lesions are sort of calcium is leaching into the blood, so that would increase the calcium level in the blood. Also, I would do a pain assessment. You know, is there a new pain or a differing pain? And that would give me some information about how bones were doing. The next so-called stubby finger was to assess organs. I mentioned last week, and we mentioned a lot that myeloma loves kidneys and it loves bones. So we're certainly always keeping an eye on patients' kidney function through something called creatinine and creatinine clearance. Creatinine is really a waste product. And if the kidneys aren't working efficiently, the creatinine will start increasing in the blood because creatinine is always excreted through the kidneys. So every time a patient would come in to see me, absolutely every time, I would do a check their creatinine to sort of see where it was. There are many myeloma patients that have elevated creatinine anyway, and that's their baseline, but we wanted to make sure it wasn't bumping up. And then the last two stubby fingers are light chains and monoclonal protein, which Dr. Reese is going to be speaking to in a few minutes. The heart in the middle, I always said to patients, the heart in the middle was them. And because an experienced clinician, whether that's your nurse, your physician, a physiotherapist, we get to know our patients very well. So sometimes just when a patient walks in to see us, we pretty much often know, is this a good visit or is this going to be a challenging visit? Because patients, will look more fatigued or more worn out, or they'll be looking fantastic. So the most important assessment of all is the patient themselves. Slide, please. So the complete blood count is referred to as the CBC. So the first thing that we're really looking at in the CBC is hemoglobin. Now, hemoglobin there are red cells, and red cells carry oxygen to our body, to the rest of our cells in the body. Low hemoglobin is often referred to as anemia. The anemia that myeloma patients experience is very different than, somebody who is anemic for other reasons. And I would often get questions, well, should I eat more red meat, or should I take iron, et cetera. And in myeloma patients, we talked last week about how the myeloma growing in the bone marrow, if there's not enough room left over to make good cells because the bad cells are taking over, that will certainly can result in anemia. Patients with anemia, or with low hemoglobin rather, they can really feel pretty lousy, and they may complain of significant fatigue, or feeling very dizzy, looking very pale, feeling quite short of breath, feeling weak, feeling cold, sort of having cold intolerance that they can't get warm, and even sometimes chest pain. So these are all things that we chat about during a visit. How are you feeling, etc. So again, it goes back to the patient in the middle of the weird clown hand. Slide, please. it's really very, very important to understand that what is normal, whether it's hemoglobin or other blood counts, what's normal to a healthy person that does not have a myeloma diagnosis or another type of cancer diagnosis, their normal is quite different to a patient with myeloma. For instance, and when patients started having the ability to see their chart, which I think is really awesome, in most circumstances, patients would get rather distressed because it, at least at Princess Margaret, an abnormal blood count will have a star beside it. Now, remembering that they are basing this on a normal hemoglobin. So a normal hemoglobin for, you know, a 22-year-old young man is certainly going to be different for someone who's older and or has a myeloma diagnosis. So when you see that a normal hemoglobin is between 140 and 180, and patients are distressed because, well, you know, my hemoglobin, I would have patients say, my hemoglobin is only 100, and I'm like, 100 is really good. We really like that. That's a great number in our area. So we don't expect hemoglobin to go back up to what it was prior to a diagnosis. It's also important to understand, your clinician would understand that patients who become very dehydrated, and you can become dehydrated if you're unwell, if certainly if you're not drinking enough, but also if you get a GI bug and you've had vomiting and or diarrhea, that will artificially elevate your hemoglobin. So I think it's very, very important to always remember that what is normal is not what we would expect for myeloma patients. So I think that can take away some of the burden of worry for a lot of patients. What's most important is not the one time number, but what the trend is. So we can see, you know, patients who are trending down over a period of time or trending up over a period of time. That's what we're looking for. And often if a patient comes in and they're you know, whether it's their hemoglobin or other counts are really sort of not what we expected, you know, it's pretty often that they will have blood work done, say in just another week's time or another 2 weeks' time to see where things are at. Slide, please.
If I may interject.
Of course.
There's several other themes that I think you've hit on. One is that we have a big buffer for our organs, and one does not need a normal hemoglobin to function completely fine. You need a certain level. A hemoglobin of 60, you're not going to feel well. But like Suzanne said, and everyone's a little different, a hemoglobin of 100, unless you're going to go out and play a hockey game at full speed, you're in pretty good shape. And that theme is the case for really all of our blood counts. The other is about the trends. If you take a sample of blood and put it through the machine that measures your hemoglobin, it will spit out a number. You take the same vial and you run it through the same machine, and you may get a few points different. And the lab's machines or instruments are all calibrated that they can't be 60 or 100, but a few points are acceptable. So those minor variations that to us look minor but may seem significant or major need to be taken with some of that awareness and check with your provider to see, does this mean something? Because of course we hang our hats on those lab values. They could be very important, either good or bad. So I think those themes are quite important. The last one is back to the fact that a blood count, a CBC, is run through a machine. It spits out a whole row of numbers that talk about the size of the white cells, some amount of how much variation in size. We really only look at three things. We look at the hemoglobin, the white count that you'll hear about, and the platelets. The rest of it is of minimal utility, but the machine can spit it out. So when you see those stars for all those numbers, we need to keep it in perspective about what it's really telling us about our health.
And thanks, Dr. Reese. And just to add to that, I just had a thought that it was certainly my experience, and I bet yours as well, Dr. Reese, that when patients are first on treatment, and with a new diagnosis, and you know, say their normal hemoglobin was 129, say that was their baseline, and now it's hovering around 100 or a little below, and at first the patient may feel quite run down and fatigued. But you know, humans are, we're really quite remarkable. Patients seem to really very quickly adapt to functioning with a particularly a lower hemoglobin, so I think that it's and by the grace of whomever that happens, that patients, you know, do start feeling better, even though their hemoglobin might never get back up to 130. So it's again, it's something that, and that's why patients are, you know, have multiple visits, and so we can keep an eye on things.
Now I know one more thing. I can't help
Yep.
myself, Suzanne. We're not supposed to talk about what we do about low hemoglobins, but to give, or these tests just yet, but to give you a perspective, having been in the field many, many years, when I was in training, we felt that blood transfusion should be given to keep a hemoglobin over 100. And then it went down to 90. And then it went down to 80. And now there are certainly circumstances where it is acceptable to let the hemoglobin be as long as it's over 70. Now, again, it's different for different people, but sometimes you can diddle too much with the body's ability to compensate for what's going on. So I think there's a lesson to be learned. Just because we can do something, we want to, because all our treatments can have consequences or side effects. So there's often more to it than a simple story about one number.
Absolutely. And I can't help myself either. While we're on that track, you know, I think
we're
going
only
back
on about the fifth slide.
it's be going back to the heart in the middle of the weird hand. It's really very often how is the patient feeling, and how are they managing. You know, I've had patients that at, you know, a hemoglobin of 70, they feel just fine. And I remember a patient, if her hemoglobin dropped below 90, she couldn't function. So it's really about the total assessment, not just the number. So as Dr. Reese mentioned, when we get the blood work back from the lab and we're looking, you know, they're again have all these different numbers, but we're really looking at three most important things. And neutrophils are part of the white cell, and neutrophils are very, very important. Basically, they grab on, they capture and destroy any microorganisms or bacteria that has been introduced into the host. So low neutrophils, which is referred to as neutropenia, certainly leaves patients at higher risk of infection. Slide, please. So a normal neutrophil count is between 2.0 and 7.5. Now, very often the patient will be prescribed a drug like Neupogen, which will bring up the neutrophil count. So and even though it's artificially brought up, and we're going to talk more about what we do when counts are out of whack, or that aren't normal, I shouldn't say out of whack. It doesn't mean that they're not real neutrophils. They are real neutrophils. One of the things that you'll hear in the waiting areas, something called febrile neutropenia, which is very worrisome to patients with specifically leukemia. Myeloma patients, even if we get the neutrophil count to be at a normal level or an acceptable level, and that myeloma patients are always at risk for infection. And that's why when we chatted last week, we talked about the real importance about ensuring that all of the patients' vaccinations are up to date. We're heading into flu season now, and we all need to make sure that we're well vaccinated. Slide, please. So the third of the important things that we look at are platelets. So a normal platelet count is between 150 and 400. Like other blood counts for myeloma patients, both the disease and treatment can affect these results. As Dr. Reese mentioned, we have side effects of our treatment modalities, and very often these side effects include blood counts being affected. As mentioned earlier, Dr. Reese and I will be speaking to what these counts all mean, and what we actually do, what our response is when platelets are low or hemoglobin is low, and what we can do to rectify the situation. Slide, please. So low blood or low platelets, the medical term is thrombocytopenia. If platelets are low, it can be life-threatening because it can lead to catastrophic bleeding episodes. That being said, it is so very, very important that patients with myeloma that tend to be thrombocytopenic are very careful, because if there's a fall, and if the head is gets the brunt of the fall, and there's a bleed into the head, this could be a life limiting situation. So very, very important. If anybody is ever told that your platelet count is on the low side, be very, very careful to not fall, using walking aids where appropriate. And Dr. Reese is going to be speaking about bone stuff in a minute. And not only can you bump your head, but you can break a bone. Sometimes platelets get quite high, and if platelets are elevated, this can result in blood clotting. Patients will potentially end up with something called a deep vein thrombosis, or a DVT, or a blood clot in the lung, a pulmonary embolus. So this is again why those three things, the hemoglobin, the neutrophils, and the platelets, are so important for us to monitor closely. Slide, please.
I'm going to interject
Yep.
too, that we pay attention to these values to guide the doses of our treatments, our side effects, how patients feel. But when we talk more about clinical trials, one of the features we have to keep in mind is all these trials require that the blood counts be at a minimum certain level as part of their eligibility. And I'll just mention that one that we're very conscious about is the platelets in myeloma are often an important limiting factor. If the platelets aren't at a certain level, the trial can't be offered. So we continually push the trial groups, be more liberal, with this. But again, we'll talk about that, and I'm probably getting the cart ahead of the horse one more time.
Not at all. So Dr. Reese is going to take it from here for a bit and speak to monoclonal proteins and light chains. Thanks, Dr. Reese.
Yes, no, I get the last two fingers on the clown hand, and a little bit about bone. So we talked in our first session about that in myeloma, we don't measure easily the content of the tumor in the bone marrow, because our bone marrow is from our head to our toe. But we measure the product into the bloodstream of the myeloma cells, because for all except a small number, 1 or 2% of patients, the myeloma cells release what they were programmed to do into the bloodstream, and that's an antibody. An antibody usually has two parts, but it also overproduces the light chain, which is the little nubbin here, and we can measure the intact antibody. You can call it an immunoglobulin in myeloma, just due to its configuration as either an IgG or an IgA. And it is its short chain, its light chain is either a kappa or lambda. And these products are used to monitor the disease. Next slide, please. So the whole antibody, the IgG or IgA, is measured by the serum protein electrophoresis, or SPEP. There are a lot of names: the M-spike, the monoclonal protein, the myeloma protein, the paraprotein. We typically measure it at least every month initially. Sometimes when people are stable, we'll go a couple of months, rarely much longer, but it is our tumor marker. And we'll also measure in the blood the small fragment, as I mentioned, the free light chains, kappa or lambda, with a blood test called the free light chain. I'm not really going to talk about the urine. The unpleasant 24-hour urine measures these free light chains on the right that have spilled into the urine. And it is a test that has utility at diagnosis and potentially periodically during treatment. Clinical trials often want to follow 24-hour urines, but for most people here, it's really the serum protein electrophoresis, M-spike, and the serum free light chain levels that will be monitored each visit. Next slide, please. Now, one of the challenges in trying to follow one's own blood work is every lab reports serum protein electrophoresis results differently. And I actually pulled a sample from our EPIC system that many hospitals used, and there were so many words and lines for this simple test. I had to white out half the things on this slide because it was a bewilderment of numbers that, just like spit out from a CBC, really want to hone down on what's important. And I'm just going to walk you through this, so hopefully it helps you know what to look at when one is handed a printout with a number of numbers and figures. So this is a 68-year-old gentleman with IgG kappa myeloma, and we're at diagnosis. His M-spike was 28 grams per liter. And M-spike should be 0. We should not have a monoclonal excess antibody. We have a mixture of all kinds directed at different bugs. Now, this patient was treated a while ago and had Cybor-D induction. And after 4 cycles, the M-spike had come down very nicely to 6. Once it's come down by half, that's the first level of remission. We call that a partial response. It's come down 90%. It's a very good PR. If it disappears, it's a complete response. So here, the patient goes to transplant, and 2 months later, it's come down from 6 to 3.9. That's good. We want it to go as low as possible. And then, as is done traditionally in Canada, at 3 months, lenalidomide low-dose Revlimid maintenance is started. And then a month later, the M spike is down to 2. A month later, it's down to 1.6. So the maintenance is actually cleaning up some leftover myeloma cells after the stem cell transplant. Then we get to September, and the SPEP can still tell there's a little bit of IgG kappa, but it's too low to even measure, which is good. And then 7 months later, it's still too low, and I didn't go on, but eventually it's not measurable, and that patient is in a complete response. So this is our tumor marker, and it's come down from 28 to where it is too low to quantitate, and that's all very consistent with a good response. It's not rare to see after a transplant, the first few months, there's still a little bit left over, and it goes down with time. So the best response may be a number of months after the transplant. Next slide, please. Now, 15 to 20% of patients we've discussed before, their myeloma cells don't make a whole monoclonal protein. They only make the free light chain level. And this is from our EPIC report in a 75-year-old man who only had kappa light chains secreted into the serum. So this individual had a MGUS type smoldering phase, and you can see the free kappa and free lambda are very low. Here are the normals, sort of from 3 to almost 25 to 25. And these are ballpark levels. These are normal kappa and lambda made by all our healthy antibodies. And I like to lump things and eyeball things. So if you look at these, normal is about 20, and the normal ratio is around 1. So here, though, they don't give you a ratio. That's because the levels are so low, they couldn't get how low they were, so you can't make a ratio. It doesn't mean anything bad. But over time, you notice here, the kappa is up a bit. Here you can measure the lambda, it's normal, so the ratio is over 1. Well, this is evidence of mild activity, I would say, of the kappa. But then a few weeks later, there's a marked increase in the free kappa level. It's gone up 10 times. The lambda in this assay is quite low. Again, you can't get a ratio, but you can see this is many times 20. So this is a concern. The myeloma is definitely active. And the next value, well, is it really coming down? Is the patient getting better? No, the free light chain levels, just like the hemoglobin, neutrophil count, creatinine, there's a little bit of variability. You have to watch the trends. And here, the next visit, it's gone up another 100 units. Here you can measure the lambda, so you get a very high ratio. So you can see a picture with a blood test, what's happened over several months in this individual. If we can also, with many systems, trend this out over the years. And this individual has had, this is the kappa level. Normal is up to about 20. And you can see here, there's a rise to 200. That's one recurrence. Treatment was given, was effective. A second relapse, further treatment, the level came down to the normal range. And then here is where it had gone up to the 500. So you can trace fairly well. You get a representation of what's going on in the marrow from the use of this test. Next slide, please. Now I'm going to switch gears a bit and talk about bone damage, that other biggie in myeloma problems and challenges. I've shown here a bit of a bone structure, and this is a leg bone, a femur, and if you cut it this way and look at it, it's like when you would snap a chicken leg bone, you have the bony casing or the cortex that's made of calcium, keeps it strong, gives our body form. There's a little bit softer bone, spongy bones, and this is the bone marrow. This is where all our blood cells are made, good ones. This is where the myeloma cells live. And if the myeloma cells are active and growing, they can eat away at the bony casing from the inside out, thin it, and make something that we call a lytic lesion. This is a little lytic lesion, same leg bone. This is a bad one where there's a lot of bone eaten away. You can see from the inside out and in here. And if it disrupts the bony cortex so much, normal walking or pressure can cause a fracture. And a fracture without trauma is called a pathologic fracture. And normal activity has caused a broken bone. And it's what we want to anticipate and prevent and minimize in this disease. Next slide, please.
Before we go on to the next slide, if we can just go back, Lydia, thank you. So an important thing for the patient and their loved ones to remember that these pathological fractures can certainly occur anywhere, certainly in the hips. We see them in the hips, we see them in the spine, and or in the vertebrae rather. And if a patient, someone who's 64 years old and they say, oh, my hip is sore, and they go, oh, well, I was gardening this weekend or something, and I've twisted something. But for a myeloma patient, it's very, very, very important that you speak to your provider, because often what will happen in the beginning, it'll be a very small fracture just at the top of that femur, which can easily be addressed with often with just a little bit of radiation. But if the pain is not, if it's sort of ignored and it's assumed that, well, I've got aches and pains everywhere because I've got my joints are getting old, then the patient may end up, and I've certainly saw it happen a number of times, having to actually go into the operating room, have a total hip replacement, because now it's a big fracture because it wasn't addressed early on. And when a patient goes into the operating room and has to have a joint replacement, that's when we have to often hold treatment for a little while. And we don't want to hold treatment if we don't have to. So any sort of new hip or low back pain or any back pain, it's very, very important to let your team know about it. Thanks. Sorry for the butting in there.
No, I think that's an important point, because I think we do tend to delay aches and pains, and sometimes the healthcare system does too. Back pain is extraordinarily common. Myeloma, not so much. But if someone has a diagnosis of myeloma and a new pain, my line to a patient was, don't wait, come, we'll take a picture of it. Let's just not second guess or minimize it. Let's find out. If it's a non-problem, if it's a false alarm, terrific. It's not wasting resources. It's taking the bull by the horns. And because as I'll talk about in a minute, bone damage in myeloma can improve, but the bone structure does not normalize. Doesn't mean people can't ambulate and do things and be active and exercise, but we don't want it to get out of hand in the first place. So we have, fortunately, in Canada, an increasing number of imaging tests to take pictures of bones. When I first came to Princess Margaret 22 years ago, really all we had was the skeletal survey. And if we were really, really lucky, we could get an MRI of the spine. But I'm going to go through these tests and try to hone in on what each of them is best for realizing that there's overlap, and sometimes these are complementary. And it really depends in large part what you're looking for. So the types of tests we have called a skeletal survey. One can do a magnetic nuclear resonance, MRI, a CT or CAT scan, or a PET CT scan. Next slide, please. So the gold standard for many, many years has been the so-called skeletal survey. And this used to take, still does, 45 minutes to an hour, and it involves a panel of 14 x-rays: the skull, the 3 parts of the spine, the cervical, the thoracic, and the lumbar spine, the upper arms, the chest, the pelvis, and the lower legs. It doesn't do the lower arms, the elbow very well. It doesn't do lower legs. And it served us reasonably well as a screening test. The problem is about a third of the bony cortex needs to be eaten away before it will show up as a thin area, our lytic area. That's a fair amount of bone before you even see it on a skeletal survey. Next slide, please. Now, the next test that we started doing is the MRI. This has an advantage, is it doesn't involve radiation. Now, with all our x-rays, and there is an effort to minimize radiation, but sometimes it's absolutely needed to image properly. But the MRI is quite good for the spine, although many centers offer it for the whole body, not at Princess Margaret, but it can tell us several things that the skeletal survey cannot. One, well, here's a picture of the spine from the side view, and this shows the building blocks, the vertebra, the discs, and then this is what you feel in your back, those little bumps. The spinal cord is in here, and it supplies nerves out to arms, legs, etc. What the MRI can tell you is there something in the marrow, something that shouldn't be there? It doesn't tell you if it's myeloma or another cancer, or even big doses of Neupogen that make the bone marrow very active with good white cells, neutrophils, can show up as something in the marrow. But it can tell you if there's something in the marrow. It can also tell you if there's damage to the spinal cord, which is really important. Spinal cord compression can cause paralysis. It can also see the nerves coming out. These are not seen well in other imaging. And I've tried to show here an MRI sideways view of the spine. And here you can see a large something growing out of the vertebrae, pinching the spinal cord. That's here. And you see this, what we call a soft tissue mass. Much better seen on an MRI than other imaging. It, in my opinion, and I think others would agree, not so good of showing the bony casing in terms of small fractures or even lytic lesions, but very useful for looking at spinal cord, nerves, and something in the marrow. Next slide, please. Now, the CT scan, you can do a CT scan of one bone. We often used to use it if the skeletal survey was questionable, let's say in a leg bone, you couldn't tell if there was a lytic lesion. A CT scan is much more detailed. You can see this is the backbone again, the spine. You can really see these lytic lesions, and you can see here it's broken through the cortex. Very much more detail here. And you can pick up lytic lesions about 25% more on a CT scan than you can regular x-rays. Now, our hospital, and again, others, have the ability to do a whole body CT scan. And they do use low doses of radiation, so it's not very much. And you can literally image the whole skeleton in great detail, looking for subtle signs of eating away the bone. And this is important if you're monitoring someone who may have smoldering myeloma that doesn't need treatment unless that myeloma is going to cause problems. And you don't want to wait till that problem is staring us in the face with a broken bone. You want to pick up very early if there is starting to be bone damage, because then you want to institute treatment. On the other hand, we generally don't want to institute treatment if someone is absolutely fine, because they're likely going to be on it most of the rest of their life. Next slide, please. Now, finally, I'll get to PET CT. This combines a CT scan, and it's done of the whole body. So it's not as detailed. It's more a survey of all the skeleton. But what it does is it injects a radioactive tagged sugar that goes to where there's a lot of sugar being needed. And cancers love to eat sugar. And so I want to be careful to say that eating candy and sugar does not feed cancer. It doesn't make it grow. But these active cancers are what we call metabolically active. They take up this sugar that glows, and you can tell if there's a lytic lesion, and then you can tell if what is in it is living cancer cells, or it may be empty. And that means the cancer, the myeloma in that spot is gone, because the x-rays, the skeleton, when myeloma is treated, it doesn't fill in normally. You can still have lytic holes in the bones, but if there's no active myeloma in it, it's a scar. And you don't need to institute treatment if what looks like a lytic lesion is empty. There's no active cancer in it. So that's not a reason to treat it. So in Ontario, and I think many provinces now, we are funded to do a PET CT at diagnosis. It's a very good way to look at the skeletal structure, lytic lesions, and see if there is active tumor in the areas that are thinned out. And you can also reassess that later on if you're left with lytic lesions, but you don't know if they're active or not. Another advantage of the PET CT and a whole body MRI is that you can see myeloma lesions outside the bone marrow. And this is a big deal, particularly when the disease has been around a long time and has recurred several times. If the myeloma is moved outside the bone marrow, you won't pick it up when you're just looking at the skeleton. So a whole body MRI may pick it up. PET CT, I would say, is even better. And PET CT also can pick up many more skeletal lesions than plain x-rays. So sometimes we'll do a skeletal survey. If we're not sure, we'll do a CT. If we're worried about something else, we might even do a PET CT. So these are all complementary and may offer us different ways to look at the same problem. Next slide, please.
Dr. Reese, just before we go on, I often would have patients express that they were quite concerned about radiation, that they're exposed to during diagnostic tests. They come into clinic and they've got a terrible cough, and we want to make sure there's no pneumonia or a new pain. We want to make sure there's no lytic lesion or fracture. And, my understanding, and I'm not a scientist like you, but my understanding that the amount of radiation that we receive as patients is so minimal. It's really, I've heard that if you microwave your coffee to heat it up, there's more radiation. If you go on an airplane, you're being exposed to radiation. And I would really always say it really isn't something to worry about. It's more important to deal with what's going on with you at this point, and make sure that we're looking after you. Do you have any sort of thoughts or suggestions, or can you let us know, is it dangerous to have repeated imaging done?
I think that's a very excellent question, and one that deserves a quite straightforward answer. I will say that I find in Canada there's a lot of attention to how much radiation is given per CT scan, and in our field we can use low dose CT and see the bones very well. And I think that's why it's important to say that a whole body CT is low dose CT. A chest CT scan is very low dose. That's one of the best tests for looking for chest infection. And again, getting ahead of myself, as we're in the era of very immunosuppressive treatment, a chest CT scan done instead of a chest X-ray, in my mind, is the way to go, and is something we need to educate all the community centers to look at. But it is very low dose. I've been told by experts that a PET CT, the radioactive tracer, the radioactive sugar, and the PET CT is less than a chest X-ray. So I think we do always want to think about any intervention. Is it give a blood transfusion, do an X-ray? We want to think about it. But I think the risks are so low, and the information gained so valuable. The alternative is to guess about treatment, and I don't think that's safe. Are we going to give drugs that we don't need, overtreat, don't treat enough? And I think in myeloma, being proactive, preventative, nip it in the bud, no matter what the problem, is so much more helpful in the end than waiting for the problem to really show itself. Then you have so much more involved treatment needed. So I think it is way down on the worry list. And I can't say in 40 years of practicing medicine I've ever seen the need for imaging studies cause a problem.
Thank you for that. So last week we found that we didn't really have enough time for a lot of interaction from the audience, and we really, as mentioned, Dr. Reese and I and the rest of the team at CMRG, we really want you all in the audience to really feel that these are your seminars. So we have booked extra time for this seminar to ask questions. Just as a reminder, we're not going to speak specifically to a patient's clinical situation, but anything that we really encourage, your comments and questions. We want to thank you so much for, excuse me, sitting through the last hour. We originally had planned for a series of about 7 seminars. This whole idea is evolving rather naturally, and we're thinking about other different things that we could speak about, but we want to hear from you what you would like us to address in a seminar. Next month, what we would like to do is a follow-up from tonight. that we'll talk about, well, what is done when someone has anemia, or what is done when someone's neutrophils are low or platelets are low, or has a potentially ominous looking CT of the spine, etc. So I think that's what we're going to do next in our next seminar. But again, we really want to hear from you what is on your mind, what you would like to hear more about. Some talks will be very clinical. We're going to also have other talks that are really more about the psychological or psychosocial issues of having a myeloma diagnosis. So we've got a hand up already, so feel free to put your hand up, and I'm happy, Lydia, to just sort of monitor who's got their hand up and who has questions. So first of all, we have Robert, then Yolanda, and then Lib. Go ahead, Robert.
Would you comment, please, on two blood count parameters, red cell distribution width and monocytes?
Want me to take that, Suzanne?
Please.
Red cell distribution, don't look at it. It, as I understand it, gives a distribution of the variation in size of red cells. Most red cells have a certain diameter, but some are littler and some are bigger. And as I recall, it gives you a bell-shaped curve. I wouldn't look at it for all the money in China. It's just spit out by the machine because it can't. You're going to find out from your hemoglobin if there's a problem. The monocytes, Suzanne talked about your white blood cells. We have a number of white blood cells. The most important for the first line of defense for infection are your neutrophils that we talked about, being neutropenic. We also have lymphoid cells that are part of our immune system, but they don't swallow up bacteria. They work a different way, and we'll be talking about lymphocytes later on. We have eosinophils that are important in allergy, basophils that are important in allergies, and we have monocytes, which are another white cell in smaller numbers. There is a normal range for each of these. Monocytes are often come up a little bit as our marrow recovers from certain chemo. They are involved in fighting infection, but in a different way. Unless they're sky high, which again is not part of myeloma and would be vanishingly rare under any circumstances, you don't have to worry about them.
Thank you. Yolanda or Yolanda, go ahead.
Yolanda, hi.
Yolanda, hi.
Hi. Dr. Reese, at which point or at what level would you treat a low neutrophil count with Neupogen?
I'm laughing. I'll let Dr. Reese answer, but I'm laughing because I worked with 8 different hematologists, and they all had their own idea. So there you go.
Oh.
It depends. And I'm not trying to be slippery.
I know
Normal low level is 2.0. Our body can fight infection pretty darn well to a level of about 0.5.
Oh, wow.
0.5 or 1.0. Not quite normal, but do pretty darn well. On the other hand, if you're below 0.5, one is very vulnerable, and I think it's fair to say I would think of as a sitting duck for an infection at some point. You have to think of the whole context. If someone's neutrophils are going to be 0.5 for one day a month and then bounce back up, well, maybe you just let nature take care of it. what if there are other factors that are impairing the immune system? What if someone's on really big doses of dexamethasone, which weakens the immune system? What if the good antibody levels are rock bottom? What if someone's on chemo that is very immunosuppressive? You know, I might not want the neutrophil count to ever go below 1.0 or 1.2. So it depends on a lot of things. But again, we have a great buffer. We don't need a neutrophil count of 5, but we do need it 0.5 to 1 for most of the time. Does that answer your question?
It sure does. Thank you.
Thank you. So next we have Lib, and then I'm going to address a question that can't tell who typed it, but and then after that question it'll be John and then Sandra. Go ahead, Lib.
Hello, Mike. I have two questions, actually. My first one is, where can we find the M-spike? It's not one of the names on the blood test results. And I've looked in all kinds of the titles, and I haven't been able to find the M-spike.
Electrophoresis.
Protein electrophoresis. Okay, I've looked at that sometimes, and I can't even find it there, but I'll try again.
I would suggest asking your provider, what does your lab call the monoclonal protein? Because it should be indicated in some terminology. Otherwise, what are you following? A serum protein electrophoresis, just like a CBC, is going to spit out a bunch of numbers. But the one we're really interested in is that monoclonal protein, M protein, in grams per liter. If it's too low to measure or not there, it won't read out. It may come out in a different column. It often lags in its reporting, but it has to be somewhere on an SPEC.
Yeah.
So I think what does your lab report it as?
Yeah, we're at PMH, and I've looked at that serum protein electrophoresis, and I've not been able to see ever. Sorry, once I did, but most recently I have not been able to see a number for M-spike, nor something saying M-spike and not discernible. You know, it's just not there at all.
Now, occasionally it should be run. Sometimes it's not run or it's not there. It's under control, and there won't be anything there because it's not there normally.
I miss it too, but it is in the protein electrophoresis report. You have to read down to the bottom line.
Okay, did you have a second part to your question, Lib?
Yeah, I'll follow that up somewhere else because I have read to the bottom line and it's not there. The other one was, you mentioned a way of treating the low neutrophils. Is that the same as Grastafil, or what's the difference between those two treatments? The one you mentioned in Grastafil.
Grastafil, Neupogen, it's brand names, but
Okay.
but yeah, the same. And again, as Dr. Reese mentioned, it's really patient specific and provider specific. So I'm going to, someone has posted a question online. I have IgA kappa multiple myeloma. My immunofixation results now say, quote, trace monoclonal IgA kappa and trace IgG lambda. What does this mean? Go ahead, Dr. Reese. Yeah.
It could mean several things. They're describing a tiny amount of the tumor marker, but there's another monoclonal protein, and there are circumstances where this serum protein electrophoresis will pick up more than one. What's very common is after a stem cell transplant, because that knocks everything down, and then the normal antibodies have to grow back, and they may grow back and overshoot a little bit as they're trying to recover all the normal antibodies, and they may overshoot with a good antibody that can be picked up on electrophoresis. And I've seen people that were IgA kappa, and right after transplant, they have an IgM lambda and an IgG kappa. Maybe they have the original one or not. Finding those different monoclonal antibodies after a stem cell transplant has repeatedly been shown to be a good prognostic sign. It means that person has a really good immune system that's waking up after a stem cell transplant. And those new antibody levels that are picked up on the electrophoresis may persist a year or longer, and they may settle back down, but they're not, the myeloma doesn't change. It doesn't go from IgA to IgG. Another circumstance is very rarely after a severe infection or maybe a vaccination, the good immune system is stimulated enough to make an antibody high enough to be picked up transiently on electrophoresis. A few people do have myeloma, and they have MGUS with another monoclonal antibody that's never going to get them into trouble. The last circumstance is people on daratumumab or isatuximab. That's an IgG kappa drug. And you can pick that up for people in the electrophoresis of people who have been on those drugs a long time. You're just picking up the drug. It's not the tumor marker. Does that answer your question?
Just a little bit of housekeeping, guys. If you're not actually asking a question, can you please make sure that you're muted? We're getting a fair amount of background noise. And Yolanda, did you have another question, or is your hand just up from before?
No, it was just up from before.
Oh, thank you.
Thank you.
All right. So next we'll hear from John, and then we'll hear from Sandra, and then Sharon Sauvé, I will address your question. Go ahead, John.
Well, John isn't here at the moment. His wife
Okay.
is here using his computer, and I'm the one with the myeloma.
Well,
But
there you go.
I just
Well, you go ahead, not John.
Okay, I'm Judy.
Hi,
And
Judy.
I just want to know if someone has missed a session, is there a way of picking it up? Have you got you know, a way of you know, copying a session that someone can get online?
Well, I know that Lydia right now is recording the this session. Lydia, can you speak to that question?
Yes. So what we're going to do is we're going to email all the participants the link, and we're going to post this video on our YouTube channel.
Oh,
Perfect.
you're going to put it on.
Yeah.
You're going to email the participants.
Yes.
Yeah,
The link to the video where you can watch the video.
and then you'll be able to see it on
YouTube.
On YouTube.
Yes.
Yeah.
We have a YouTube channel.
Oh.
So you'll be able to catch up, or, you know, sometimes people will even want to go back to seminars that they were at, but they want to go back and think, oh, I think they said that. So that's a great question. Thank you so much. Not John.
Oh, that's all right. His computer screen is better than mine.
I hear you, sister. And next, thank you
very much.
Thank you. Sandra, what can we answer for you?
Hi, Suzanne, and hi, Dr. Reese. I actually have two questions. Now, Dr. Reese has earlier spoken about the amount of radiation that people picked up from all sorts of imaging tests. And you mentioned that CT, you can go very low dose. And my first question is for a skeletal survey, because there's altogether, you mentioned 14 pictures. So what is the amount of radiation there involved? And my second question is, if somebody has gone for a low dose CT this year for a follow-up the following year, the next year, should we go with the same sort of test, or can we go with a skeletal survey? Is it better, or does it matter? Thank you.
The first question, I'm sorry, I can't give you the total dose of radiation with a skeletal survey, but as you might imagine, it's a fair amount if you're x-raying 14 different bones. We tend, when we monitored people with this in the past, we would do it once a year. That still felt to be a safe level, but I wish I could give you numbers. But it is, I could probably get that information somewhere, but I think going with the skeletal survey with a CT compared to a CT, my best guess is you're not getting more with a CT than with 14 x-rays. So I think they're all, I think there's nothing wrong with going to a CT. Your second question about what technique you should use, it is easier if the same imaging study is repeated. You know, because if you are x-raying a leg bone and it shows a lytic lesion with a regular x-ray, and then your next scan is a CT, which shows much more detail, it could look a lot bigger, and you might see other little lesions you couldn't see on the regular x-ray, and you might think the disease is causing more bone damage. And that's been an issue in the past. You have to be very careful that you're comparing apples with apples and oranges with oranges. On the other hand, radiologists in Ontario, at least, are very good about lining up. If it's an MRI, a CT, a regular x-ray, they'll line them all up and try to interpret, you know, changes over time. But I think if we had our preferences, it would be the same technique. But again, if you're just looking for lytic lesions, CT is good. But what if you want to know if there's living cancer in one of those lytic lesions? Then you're going to want to go with a PET, but it also has a CT component.
Okay, thank you.
Thank you. We have a couple of questions that have been sent in by text. I'll read the first one. My husband is smoldering, but beginning treatment soon. In 2017, he had a DVT and double or bilateral pulmonary embolisms. He is on Xarelto. What should we watch for? I'll try this one, Dr. Reese, and you can jump in if I blow it. So very, very, very good question. And we see this a lot. The first thing to know is, regardless of what type of cancer a person has, all cancers make you at higher risk for blood clots. So and in myeloma, there is some treatment that makes a patient have even higher risk. The important thing is to make sure that the patient is, if it was 2017, the family doctor may have taken over the prescribing for the Xarelto after so many years. Very, very important, I would think, to include the thrombosis team in the circle of care for this patient, to make sure that there's good communication, and again, by having all of the patient's blood work followed very closely, it's going to be helpful. Really, again, I think the most important thing is that all the whole team surrounding your husband knows about the previous clots, knows what medication they're on, involving a thrombosis expert. And another thing I think that's very important, that even on an anticoagulant such as Xarelto, patients are still at risk for a clot to break through. So don't ever feel that people are safe. The second part of your question is what should we watch for? So a DVT, and I don't know if hubby had a DVT in his arm or leg, but generally for a DVT, the limb will can often be warm, it can be swollen, it could be painful. If it's in the leg, there's something called a Homan sign, which any nurse will do the assessment, where you sort of hold the foot and have the patient push down like they're pressing down on the gas pedal. And if there's pain behind the knee, that can be indicative of a DVT. And so I think that he will certainly never be, during treatment anyway, he won't be off anticoagulation. So I think communication is certainly the key. Dr. Reese?
Yeah, I think you've hit the high points. I think your point that a thrombosis expert should be involved, if only because if there are no risk factors or very definable risk factors, sometimes the primary physician will limit how long the blood thinners are given, so many months. But if someone has myeloma and has had a clot, at least at Princess Margaret, our practice, because they've had a cancer, would be to leave them on anticoagulation indefinitely and not try to get by without it, because there's the risk factor of having had one. And then some of our myeloma drugs do increase the risk of clots a bit. It is manageable, but we don't like to back off that protection. And the blood thinners are better and better. We're not using as much Coumadin and measuring the INR so often, and they're oral ones that are making their way into predominance, although funding can be an issue. So I think not getting shortchanged, and also keeping a bit of eye on the platelets. You can give blood thinners with low platelets, but I think you certainly can do that. But again, that having that team of experts is really important to keep him safe and protected.
And I think, I talked about, what to look for DVT. Of course, the people who have a pulmonary embolus will often complain of feeling quite short of breath, have some chest pain, and that is certainly a medical emergency, and very, very important that in the emergency department, or if you call EMS, because the patient it's very, very hard without sort of real testing to know whether this is a cardiac issue or a pulmonary embolus. Patient needs to have imaging done to let the EMS know, let your triage nurse know that you have to be a great advocate for the people you love and yourself. That I've had a previous pulmonary embolus, I am on anticoagulation, but then I'm also on cancer treatment, and I'm very concerned that my husband has another pulmonary embolism, and that'll move you up the line, because we know what the emergency departments have looked like for the last many years now, and it's more and more challenging for nurses to triage, and so the more information you can give that nurse, and when you arrive, the better. I can't reiterate how difficult it is. Many triage nurses are very, very novice, and so the more information you are able to give, the better. And don't forget, we've to take all your medications with you to hospital. If you go in through Emerge for any reason, do not just take a list, actually bring the drugs with you.
And
I
don't
think
be afraid of a false alarm. I
absolutely
false alarms, and nothing makes me happier than knowing that the symptoms, when they were evaluated, were not dangerous, because you cannot tell over the telephone. what is going on. And there's nothing wrong with it being nothing, because people facing myeloma and other serious diseases have to advocate for their own health. I mean, I do find that many times Canadians, in our willingness to try to be good citizens, hold back, don't want to bother anyone. Well,
Sorry to bother you. Sorry to bother you.
there's someone sicker, but be proactive and never let anyone make you feel bad about reaching out with questions or concerns. Please, because you can't tell over the phone, and it's very hard to bless someone staying at home if they have any worrisome symptoms. It's just not safe. And that's really what it's about. It's not about convenience, it's about safety.
We have another question that has been sent in, and remember we did chat saying that we're not going to specifically look at people's specific challenges with their treatment, but I'm sure Dr. Reese can help with this. Question is, when does an increasing free light chain become a concern? For example, kappa increasing by 1 to 2 points per month with an increasing free light chain ratio over the normal range.
Now, that's a very good question that I'll try to answer in general terms. I wish I could illustrate it better, but for free light chains bounce around a lot. If we think back to the first session, I know there's a lot of information. The free light chain level measures good and bad light chains. And even if someone has kappa light chain myeloma, some of that's going to be good. It's not only the tumor marker. So it can bounce around a bit. The assay is allowed by the rules to have 7% inaccuracy. So if the real level is 100, the certification says the report can say 107 or 93. So that's the range of error that's allowed for this assay. So there's imprecision. The other thing is kappa is retained if the creatinine goes up. And if someone is running a high-ish creatinine, there's going to be more kappa, and it may be normal kappa. So the ratio, the kidney specialist will tell you a free light chain ratio in kidney insufficiency. It doesn't have to be full-blown failure. It can be almost up to 3. There's just more kappa there. It's not all tumor marker. So the other thing, the ratio, if both the numbers are low and the ratio's abnormal, forget about it. I mean, the ratio may be out of proportion, but if kappa's 7 and lambda's 1, your ratio is going to be 7. But they're both normal. That ratio it's way over 1, but they're both normal. So unfortunately, the test is useful, but it's not perfect. And a lot of particularly younger docs tend to overreact with smaller changes. So the trend is important. If the number goes from 8 to 9 to 10 to 11 over several months, and it's all normal, that could be the phase of the moon. So I'm not minimizing it, but for instance, many trials won't count the free light chain as a suitable tumor marker unless it's over 100, the bad one. So little changes may or may not mean anything, and that, of course, I will acknowledge that's frustrating because people are pinning all their hopes and dreams and travel plans on what that number is, and it's slippery.
I mentioned when we started about when patients suddenly had access to all of their reports, blood work, and imaging, et cetera, which can be a great thing. but it can also add to some worry. And I think it's very really, really important that, you know, when you are seeing your provider, when you're seeing your team, to bring these questions up, and don't be Canadian, say, I don't want to bother you, and I'm sorry, I don't want to take up too much of your time. If there's something that's really niggling at you because, you know, you've seen it on your results, you know, better to put it out there and get the question answered, so that you're not worrying about things that don't need to be worried about. So don't ever be afraid to ask questions. And I know that the teams are very, very busy. I know wait times can be terrible, and you don't want to take up too much of the doctor's time, etc. But this is it's your visit, and it's your time to be with your hematologist. So don't be afraid to ask questions. I always encourage people to write their questions down before they go into clinic, because sure tootin' they're going to forget them once they're there. So, and I speak for myself. So that we don't have any other hands up, and don't have any more questions that have been sent in. So again, if there's no more questions, many of you, we've still got over 40 people that have remained right till almost 6:30. So thank you so much for your participation. Again, if you have feedback, we welcome feedback. Email Lydia, and good, bad, or indifferent. We want to know ideas for seminar talks that you would like to hear about. And again, we're on behalf of Dr. Reese, the whole team at CMRG, and myself. We're grateful to all of you for taking time out of your busy days, and especially over the dinner hour to participate. And thank you, Robert. Robert says, thanks, an informative and useful presentation. Well, and we're happy for that. Thank you so much.
Yeah, I will just echo that, and we are completely sincere. I think Suzanne and I have tried to put together a program that is very relatable. I think both of us have given lots of talks to other healthcare providers, particularly me, and she keeps trying to keep me honest about making it relatable. And we want to hear from you, because we want to really be able to inform you about real issues that you're facing and will be facing as some of these newer drugs and treatments become available. So Lydia's been keeping us informed of your responses and feedback and questions, and we will try to get back to you on ones that we can address, of course, without offering you medical advice, but speaking in generalities, because the problems our patients face are very similar among the whole group. So I'll thank Lydia, CMRG office, and all of you for your attendance, and wish you a wonderful rest of the evening. Till next
Thank you,
time.
everyone.
Good night
Have a
now.
good night.